Good morning, everyone. I'm welcoming everyone to this third plenary titled The Private Sector in Health, the Polemic and Pragmatism. My name is Cloete. I am Ministry of Health in the Western Cape in South Africa, and I'm proudly identifying myself as a policymaker at this conference. Before we start with the proceedings, I'm going to call on Asha George to do some housekeeping. Thanks, Asha.
Good morning, everyone. It's exciting. Thanks so much for showing up early. We have a very exciting plenary. So I won't take too much time. We have over 2,000 people here, 140 countries represented, as Kabir said, and we have 140 pages in this program book. And there's so much going on in the symposium, I'm not sure that you've read every page in the symposium handbook. So we thought having a few housekeeping points in the plenary would help orient all of us to make sure that it's a huge logistics exercise, bringing us all together and getting us to all the different places we need to be, the people we need to meet. So I wanted to clarify that today we will be having an AGM. There will be lunch available, and it'll be available at noon. There will be bento boxes, and for those coming to the AGM, there will be bento boxes outside here. It's very challenging for the venue to have food for almost 2,000 people all in one location. So we'd encourage you, that's why they try and have food at multiple places and encourage people to go to the poster and exhibition area, because those are the priority stations that they try and empty out first. So just be mindful of that, and there are over, amongst the 2,000 participants here, there are 600 people who have specific dietary requirements that were registered that were taken note of during registration. So if you don't see what you requested at the stands, there are people in green T-shirts. So please reach out to them if you don't see what you need, what you requested during registration there. The other things I wanted to remind you is, apart from the AGM, we're going to have a fantastic evening at the cathedral. But to get there, you need to have your ticket, and that was given to you, so make sure you have your ticket. And it's only 15-20 minutes walking distance from here. But there are further instructions on the website, both for the shuttles and for how you get there. So we'd encourage you to just go to the website. And we look forward to being with you over the next few days. So if you have questions, please reach out to the volunteers as well. Thank you very much, and let me hand back to Keith.
Thank you, Asha. So back to the business of this plenary. We welcome you to this very exciting session on the private sector and health systems. In this session, we will be engaging all the key debates, and we will be considering options of how to engage the private sector to make a positive contribution to population health, while recognizing the risk that an unregulated private sector can pose to the health system. We'll also take a much broader view of the private sector, from the smallest provider in the local community to multinational global companies. That's the private sector. And I guess you could also say that the views are from as left as you can get on the negative experience of the private sector and as right as you can get in terms of the positive experience of the private sector, let alone views from local communities and multinational players. So it promises to be a very exciting engagement. And the structure will be that we will have two inputs to set the scene, which is followed by a very interactive and exciting panel discussion that will follow. So it gives me great pleasure to introduce the first speaker, and that's Catherine Goodman. Catherine is a professor in health economics and policy at the London School of Hygiene and Tropical Medicine. She has 20 years experience in applied health systems research in low and middle income countries. Her work focuses on the understanding and improving private sector healthcare provision. I welcome Catherine. Thank you.
good morning, everyone. So the quite big question I'm going to pose today is the private sector the answer for global health? And as we've heard in our conference theme, which is from polemic to pragmatism, the role of the private sector has been the subject of a great deal of polemic debate over the decades. On the one hand, we have those people who feel it is definitely not the answer, that we need to be focusing on publicly provided care and minimizing the role, particularly of the for-profit private sector. On the other hand, we've got those who see multiple opportunities from working with the private sector and see it as a potentially part of the solution in global health. So this morning, I'm going to take a look at what the evidence might have to say on that topic. But before we embark on that, I want to pause a moment to ask what we mean by the private sector and how what, say, you mean by the private sector might differ from what your neighbor means by that term. So to some, the private sector is going to really mean private facilities. But of course, we've also got the drug retailers as well. And we've got other private entities like private labs, private blood banks. We've got the wholesalers and distributors that supply them, and the manufacturers that supply them in turn, and the tech companies. And then on the other hand, we've got private insurance firms, or also on the finance side, private equity investors. And then for some people, the private sector means more about the big companies that may not produce healthcare, but certainly influence it. So we sometimes have a tendency to lump all of these incredibly diverse entities together under one heading for, say, a report on the private sector, a commission on the private sector, or dare I say it, a conference theme. But I think if we're ever going to have some constructive discussion, we really need to focus down and talk about individual elements of this whole area. And also have some precision in our language. I'd quite like to ban the term the private sector altogether, because I've seen it be the source of so many cross-purpose discussions with people thinking of very different things. So this morning, I'm going to try and follow my own advice about focusing, and I'm going to restrict my comments to private sector provision, and looking particularly in low and middle-income countries. Having said that, I'm still leaving myself with an incredibly diverse range of providers to consider. So we've got for-profit facilities ranging from big corporate hospitals down to small clinics. Then we've got the not-for-profit, often faith-based sector. Turning to the drug retailers, we've got little drug stores, we've got pharmacies with qualified pharmacists, we've got an increasing role for pharmacy chains. And then we've got the type of providers who are completely outside the formal sector, so unqualified informal clinics, or even market stalls and itinerant vendors selling drugs. And there are lots of overlaps. Those categories aren't distinct. They're quite blurred boundaries between them. And we may not even see a provider at all, because increasingly we may be using our devices to access e-pharmacy or m-health. So I began by asking if the private sector is the answer for global health, but to know what the answer is, we clearly need to make sure we're asking the right questions. So I'm going to take a look now at some of the questions that are most commonly raised around this topic. So one of the most common is which sector is responsible for most care? And I'm going to explore this using a couple of DHS analyses. As an example of outpatient care, I'm going to look at curative care for under 5s for ARI, diarrhea, and fever, with an analysis from SHOPS Plus. And as an example of inpatient care, I'm going to look at inpatient delivery, facility deliveries, using an analysis from the London School. So we often try to answer this question using quite high-level figures. So as an example, this slide is showing curative care for under 5s, looking across 24 LMICs. And it gives us a figure of 43% of all treatment across these LMICs being sought from private providers. That's shown in red, compared to around 50% from the public sector in blue. But the high-level figure we end up with, of course, very much depends on which countries we put into that average, and also how we calculate the average. This average is calculated as a simple mean across those countries. If instead we weighted the mean by population size, we'd end up with a high-level figure of 62% of under-5 treatment, reflecting the fact that private sector use tends to be highest in some of our most populous countries. But I really question whether these sorts of high-level figures are really helpful for us in advancing the debate and thinking about policy, because they conceal such a wide variation across countries. We've got everything here from 86% private sector use in Pakistan down to just 2% in Mozambique. One can see some sort of general tendencies higher in Asia for the private sector, maybe lowest in Southern Africa and some of the Americas, but even within those regions, there's huge variation. And there's also variation depending on which service we look at. So if I now turn to facility deliveries, this analysis across 57 countries shows 19% private sector share. And that's if we use a simple mean across the 57 states. If instead we weight by population, we get a headline figure of 40%. But again, this is concealing massive variation across countries. So I've got a high here in Indonesia, 77% of facility deliveries in the private sector, to just 0.1% in Colombia. Headline figures also conceal that whole variety of private provider types that I discussed earlier. So for instance, in Tanzania, the red segment of the private sector, if you break that down, we find just 7% of that is actually private for-profit facilities, 9% is private not-for-profit clinical facilities, so faith-based mission facilities, but the vast majority is private retail, and in Tanzania that's mainly drug shops. By contrast, if we take a look at India, the private sector breaks down at being nearly all private for-profit clinical facilities of some kind, with very small segments for the not-for-profit and also pretty small for the private retailer. So this private provider mix is very different. Though it's worth noting that some of those so-called clinical providers in India actually have less Western medical training than some of those Tanzanian retailers. So I've talked about variation across countries. There's also variation within countries. And there certainly can be variation across wealth groups. So this shows private sector use for Kenya and Pakistan, broken down from the poorest quintile, Q1, to the least poor, Q5. So most countries have a pattern a bit like Kenya's, where you'll see that the better off are making more use of the private sector. But you can see that's not universal. In Pakistan, it's actually almost universally high across all wealth groups. But one pattern I think we can see across nearly all countries is in terms of the private provider mix by wealth quintile. So this is showing the breakdown of private provider use by private clinical, that's facility use in red, and private retail in orange. And you can see that the richer quintiles have a tendency to be using more clinical care, whereas the poorer groups have a tendency to be using more retail care, relatively. So returning to this question, all in all, we can see that private providers can be responsible for a substantial share of care, but we can also see that it's not that helpful to debate this at a high level of aggregation. So perhaps a better question would acknowledge all these sources of variation and actually ask which specific types of private providers are important, and ask that in a specific context and for specific services and specific groups. The second major question that we often hear discussed is which sector provides the best quality care? And a number of teams have tried to synthesize the evidence for us on this area, but it's really challenging methodologically. they actually find very few individual studies that compare private and public providers within one piece of research. And there are also challenges because even those that don't tend to control for patient mix or health worker mix, and almost never for resource levels. But having said that, there are some conclusions that we can draw from this literature. As we would expect, private providers tend to be more responsive than public providers to those most easily observable elements of quality, whether that's waiting times, hotel facilities, time you get to spend with your doctor or other healthcare provider. And we also clearly see that private for-profit providers are more likely to expend resources on unnecessary services, where this could lead to an increase in their income. But the conclusion on sort of broader measures of clinical quality is that it's just incredibly variable. You can find everything from the excellent to the abysmal. And the conclusions you draw about public versus private are really going to depend on which providers you decide to compare at that point. So there are really almost as many answers to this question as there are possible public-private type pairs to compare. So I feel it's time to really stop trying to answer those very generic comparisons and instead focus in our own settings on what the most important quality challenges are, and looking at very specific provider types and which quality challenges different provider types face. Or perhaps even more importantly, asking what we're going to do about it. So what strategies we can use to improve private provider performance. So Dominic Montague and I, when we reviewed this literature, we categorized possible approaches into 4 main types under prohibit, constrain, encourage, and purchase. So when it comes to prohibition of parts of private practice or constraint of its operation, this has normally been done through statutory or self-regulation. An alternative approach, though, has been to try and encourage the private sector and perhaps subsidize part of it, using, for example, training or social marketing, social franchising, accreditation. And finally, there's purchasing from the private sector, either with demand-side financing, such as vouchers, or supply-side financing through contracting. So what can we say about the evidence base on these strategies? Well, starting with regulation, there is loads of evidence that regulation is poorly implemented. But with a few notable exceptions, there is really little evaluation of strategies to improve regulation. I sometimes feel we've almost given up on thinking that we can improve regulation, and I don't think that's the way we should go. There is a growing evidence base when it comes to the encourage and purchase side, but until recently, we also suffered from a lack of robust evaluations there, particularly on the impact of these strategies on clinical quality, on coverage at a community level, on equity in terms of socioeconomic groups reached, and on cost effectiveness. So there are many gaps, but despite these limitations, I'd argue that we can draw some conclusions from this emerging evidence base. Firstly, for relatively simple public health products, I'm talking about things like condoms or bed nets, it's clear that social marketing strategies can be very effective at increasing coverage, and that they can also do this for quite poor groups, because these products tend to be distributed through quite small private providers. But there are limits to how far you can stretch something like social marketing. It really only works for products. It's not going to work for even mildly complex services. And when we turn to those services, that's where we really hit a lot of challenges, because improving clinical quality has been shown to be very difficult. I'd even go so far as to say that I haven't really seen yet robust evidence of interventions improving quality in the private sector and LMICs which have worked really consistently and systematically. I think we're still looking for that. But one thing we can see from the literature is that if you want to have sustained improvements in quality, you need to think about incentives. whether those might be the positive carrot incentives of perhaps empanelment in a financing program, or the negative stick incentives, perhaps of having your license revoked. So the third point that I think comes out of this literature is that if you're going to work with the formal for-profit facilities, clinics and hospitals, you simply cannot expect to reach the poorer groups within society in most settings unless you have a financing component, because those poorer groups are not naturally going to be using those facilities to start with. So just improving their care is very unlikely to reach those groups. And then fourthly, many of these interventions rely on quite intensive individual face-to-face contact with small facilities or small drug shops, facility by facility. And this can work very well when you're working on a limited scale, or if you've got a very friendly donor and plenty of resources. But when you try and look at scale-up and sustainability, they do quickly run into problems related to cost and logistics. So perhaps we need to be moving on here, thinking of smarter ways to intervene in these facilities, whether that's using technology or thinking about pinch points within the system, whether that's the wholesalers or perhaps provider networks that can allow us to do this more efficiently. But I think the biggest lesson that I see from the evidence on these interventions, and particularly those that haven't worked so well, is that you must have a good understanding of your market before you can even think about intervention design. So that's partly in terms of market structure, who your providers are, what type they are, what their market share is, also who they're serving, particularly in terms of socioeconomic status. But it's not only the what of who the providers are, it's also about how they operate, how they compete with one another and how they may cooperate with one another, how they obtain their supplies, how they're regulated in practice, what their experience is in practice, how do they respond to that regulation, and then crucially, how all these elements are changing over time in what are really quite dynamic markets. And all this might sound obvious, but I do feel that we frequently see interventions that are based more on our assumptions about how the private sector works rather than a real understanding of what's going on the ground. So returning to this question, there is quite a lot we know about improving provider performance, and there's a lot more that we could learn. But one thing I think we have to be careful about is if we focus on strategies to improve existing private providers, it can lead us to quite a static approach. And we should be aware that we don't have to be passive recipients of the health systems that we have. We can also shape them. So perhaps the most important question of all for all of us is, what do we want our health systems to look like in 10 years, 20 years? And what role do we want the private sector to play in that? So there are many possible views of this. I'm going to give you an example of one from Barbara McPalce and Hanson's work. And they argued that the goal in managing private provision should be to ensure quality and safety in all public and all private providers, and ensure that the system as a whole meets the need of poorer groups. Though that doesn't mean that every single provider type has to serve the poor. They advocate strongly for universally accessible basic health systems funded by pooled purchasing, say through tax funding or social health insurance. And their argument is that having a good basic health system like that will help you crowd out the low-quality, underqualified providers in the market, basically competing them out of existence eventually, what they term regulation by competition. So while they're advocating strongly for pooled public financing, they're not necessarily arguing that all provision should be public, and they're quite agnostic about the public-private provider mix. And this is really borne out by the experience from high-income countries. So this panel is showing OECD countries, the main mode of provision. So you can see that for specialist outpatient care, in half the OECD countries, the main mode of provision is private. And for primary care, it's actually the main mode in most OECD countries. Having said that, we also need to remember that this kind of purchasing from the private sector is really hard to do well. And I think we're all aware of examples of where it has not been done well. So when you're thinking about having a vision of a system with a high share of public funds going to private providers, you also need to ask some hard questions about the government's capacity to regulate and to contract effectively. So in summary, I've got 5 take-home messages for your consideration. First, can we try to refine our discussions and hopefully improve our communication by being more precise about the terms we use to describe the particular elements of the private sector we're interested in, whether that is big pharma or small drugstores, for instance. Before we think about what to do, let's make sure we have a very good understanding of the market in question that we want to tackle. Crucially within that, let's think about the incentives that those providers face, both now and what incentives we might like them to face going forward. And let's look to the future. Let's think about how our health systems are changing and also think about how we might like to shape them. Because if we don't choose to shape them, there will very likely be other vested interests quite happy to shape them for us. And finally, let's demand robust evidence. So whether that's from our donors, from our governments, from the implementers. In particular, we need to try to implement in ways that are amenable to evaluation, and also give credit to those people who are willing to document and publicize the failures as well as their successes in intervening in this area. So concluding on this topic of evidence, this conference is the first HSR to really make the private sector so prominent. And I feel this year we really are seeing that shift in the conference theme from polemic to pragmatic policy debate. I started by asking the question of if the private sector is the answer to global health. I think we all know there's no simple answer to that question. But I feel we can feel optimistic about the huge range of focused, policy-oriented questions that are being addressed here in Liverpool this week, which I think is both inspiring and fascinating. So I wish you all a great week and to enjoy finding the answers to these and many other questions about the private sector during the conference. Thank you very much.
Thank you very much to Catherine for the thought-provoking inputs. It now gives me pleasure to introduce the next speaker, Abhay Shukla. Abhay is a public health physician who's been working on health issues in collaboration with people's movements and grassroots NGOs in Western India. He's a senior program coordinator of SATHI Pune, along with being a member of the National Health Mission Advisory Group for Community Action, as well as being a member of the core group of health for the National Human Rights Commission in India. He is one of the national conveners of the People Health Movement in India and is also a global steering committee member for COPASA. Welcome, Abhay.
Thank you. Thanks a lot for this opportunity to share some ideas, and my job is going to be to provoke you. I am the odd man out in this panel, and I will be a bit polemical because I feel that there is a need to correct any kind of over-optimistic pragmatism about the private sector, so we need to take some hard facts into account. But a few clarifications. I'll be mostly talking from the Indian context. A lot of things which I am saying are based on the private sector in India, but they have some similarity to many other countries, and they're mostly about formal providers, for-profit private providers. But I think they do have a relevance for many other low and middle income countries. And I will try to raise some questions which I feel have not been sufficiently discussed until now. So I'll start with my favorite Sherlock Holmes. There's some problem, the last point is not there. So anyway, you might have read this story about the dog which did not bark. And basically, there are some very critical questions about the private medical sector which have not been raised in the past few days. And I feel that that is the curious incident. And I'll try to correct that by pointing out some of those issues. So when we are talking about a system for universal health care, it's a system which is governed by public logic. And on one hand, there are certain key conditions for universal health care which must be fulfilled by any provider which is part of that system. And on the other hand, there's the reality of the current private sector in low and middle income countries. We need socially accountable care which observes patients' rights. But what we have is a private sector which largely lacks social accountability and often denies patients' rights. We need observance of at least basic ethics in healthcare, but we in India are seeing large-scale medical corruption. We have a need for rational care, according to at least some basic standard protocols. What we do have is what I am calling extractive medicine and a growing epidemic of irrational care, which Catherine also briefly mentioned about. We need an UHC system which will give free care to all patients, which will contain costs. And what we actually see are constantly increasing prices of care in the for-profit private medical sector, and also a refusal to go for any kind of rate standardization. We need regulation on the content, quality, costs of care. But what we do see, and which Catherine also briefly mentioned, is self-regulation has largely failed and state regulation is being resisted. So, and unfortunately, many of these negative features of the private sector have not improved much even when they are publicly paid through either public-private partnerships or health insurance schemes in India. So this is now a paradox. This is actually a conundrum. And this is, I think, one of the core conundrums of UHC. So on one hand, UHC, universal healthcare, is guided by public goals, and where we say care to all irrespective of paying capacity and more care to those with more need. Whereas the private medical sector today is driven by a profit maximization, at least the for-profit sector, which says more care to those who pay more. Now, if you look at both of these together, they are almost opposite, or they are definitely leading in quite different directions. So how do we bring these two vectors into any kind of common logic? And so basically, it's a question of the square peg of private providers being fit in the round hole of UHC. And I'd like you to, we need to think about this carefully. It's not such a straightforward issue. And the private medical sector today in countries like India at least is very powerful and very huge. So it's not a minor player. But society, which anchors this sector and which it is supposed to serve, is much larger and much more important. So therefore, society has to wake up and start thinking about how do we start treating some of these illnesses of the private sector. So I'll now try to point out a few key issues and also what can be done, because I don't want this to be a purely negative presentation. There are a lot of efforts which are going on probably in many parts of the world, and I'll just point out a few from our experiences. Patients' rights denial in private sector, basic things like right to information, right to second opinion, right to informed consent, right to records and reports have been denied on a large scale. We have had a public hearing with the National Human Rights Commission where such cases were collected. We have the medical councils have huge pendencies of complaints in many states of India. Violations are being reported in various newspapers with very shocking cases. So can we give public funds to a body which is not publicly accountable? I think this is a core question we need to ask in the context of UHC. And any provider, whether public or private, which is receiving public funds, has to be publicly accountable. In this context, a positive development is that the National Human Rights Commission of India has recently adopted a patients' rights charter. These are the rights which are given in the charter. You can see it on the website, and now the Union Health Ministry of India is taking these up. Patients' rights are human rights, and they have to be observed. Medical corruption, a growing topic of concern in India, and we have this book, Dissenting Diagnosis, of which I am one of the co-authors, where we have interviewed whistleblowing doctors, 78 whistleblowing doctors across India who have actually blown the lid on what is happening in many private hospitals, especially certain larger private and corporate hospitals. And basically, the parliamentary committee report has come out with a scathing indictment of the Medical Council of India. We have basically another book recently which has come out on healthcare corruption in India. And kickbacks are very common. One of our studies has shown 70 to 80% doctors taking kickbacks. And then irrational care. And this is a growing epidemic. And something which I call pseudo quality of healthcare. So we go to a shiny hospital, there's a very nice ambience, and then your uterus is taken out. Or you don't require a cesarean section. So cesarean section rates in India are 41% in the private sector. In the public health system, it's 12%. So now what is going on? So the indication for cesarean section is your bank balance. The higher your bank balance, the more likely are you to undergo a cesarean section. Is this what we want when we move towards UHC? And this is also continued in health insurance schemes of various kinds. The Lancet series on right care has highlighted some of these paradoxical, coexistence of underuse and overuse. So again, Sherlock Holmes has said that when a doctor does go wrong, he's the first of criminals. He has the nerve and he has the knowledge. So now, it said that to catch a thief, you have to take a thief. So let's put that around and say that it takes ethical doctors to check unethical doctors. And this is another something which we are trying to do by developing a national alliance of doctors for ethical healthcare. Doctors in India, with different parts of India, have come together to form recently a national network, which is critical of the effects of commercialization of healthcare, supporting healthcare, promoting healthcare, and coming out with position papers on rational management of common conditions. When is a cesarean required and when is it not required? When is a bypass operation or an angioplasty really necessary or whether it is not necessary? So this is a ray of hope. So we can see that within the private medical sector, there are also elements who are standing up for ethical healthcare. Regulation, I think, central to the whole, and I'm calling it stalled and failed. So in some cases it has failed, like self-regulation. In some cases it's being stalled. There's so much resistance. And there's this whole issue of regulatory capture, nominal regulation, biased regulation, corrupted regulation. And it's become really a complex area, and it's stuck more or less. So we have a Clinical Establishments Act in India, passed in 2010-11, but still not implemented in any substantial form. So, and this kind of regulation leads to resistance from both the providers and also complete apathy among the general public because they don't see anything happening. And that is where we need to think about social regulation. And we have to reimagine regulation. And regulators themselves need to become accountable. It cannot just become an arena of corruption. And social regulation would have a combination of state regulation, multi-stakeholder bodies which are providing oversight and holding accountable the regulatory framework, and also an element of self-regulation on the technical side by diverse medical professionals, not just one particular kind from the private sector, but rather all of different kinds of medical professions also coming together. So if we think about social regulation, we might be able to reimagine the whole scenario. And then finally, another issue which I'd like to flag is growing global investments and corporatization of healthcare in India, which is also affecting other countries. And the Indian model is not a great model, and unfortunately we are exporting it to other countries. We are now exporting it to South Asian countries, to East African countries, our Apollos and our Fortises. So, I mean, but this is a larger scenario of global investment in healthcare on a very large scale, IFC, CDC, venture capitals getting into healthcare in a major way. And this is accompanied by corporate hospitals, rise of corporate hospital chains, adoption of corporate practices on a large scale, and smaller providers being gradually squeezed out. These kind of globalized financial investments are, I think, a very serious issue which we need to look at, and what is the impact that they have on the provision of healthcare. And when we are developing a UHC system, we need to take a differential approach to different kinds of providers. We cannot take all of them in the same category, and how do we look at aggressively profit-centered bodies like this. So this is my last slide. There are two contending logics in the health sector. In many countries, there's a big profit logic and there's a smaller social logic. But as we know that for UHC, the social logic has to prevail over the profit logic. And If some profit logic will remain, but the social logic has to become larger, this is the change. And this is the change that has to be ensured while we deal with the private sector. Any genuine UHC system will have to treat these serious illnesses of the private medical sector. These are not going to go away on their own. Public action is required, and we need to decide what kind of UHC do we want. Public resources being used to strengthen the private sector, or private resources being used to strengthen the public system. Thank you.
Thank you very much, Abhay. So you see, Abhay has set the scene for the panel discussion. I'm going to introduce Cara Hanson, and she's going to bring the panel to the fore. Cara is the Professor of Health Systems Economics and Dean of Faculty for Public Health and Policy at London School of Hygiene and Tropical Medicine. She's done lots of work, and you would have seen recently, together with Barbara McPaig, she co-edited the recent Lancet series on the private sector. So Cara's about to introduce the panel and lead us in a very lively discussion. Over to you, Cara.
So good morning, everyone. And let me first just begin by thanking our speakers. I think they've set the stage really well for this further discussion that we're going to have in this panel group. I am absolutely delighted to introduce the people that we've put together to have this conversation. So Catherine and Abhay, you've met already. We have Hari Thalapalli, who is the CEO of Call Health. That's a startup based in Hyderabad that is creating an interface for bringing together virtual and physical healthcare services. We have Akaki Zoidze, who's the chair of the Healthcare and Social Issues Committee for the Parliament of Georgia. So he brings a policymaker perspective and the perspective of someone who is working in a country where the private sector is by far the predominant provider of services. We have Githinji Gitahi, who's the group CEO of AMREF Africa, and brings the perspective of the nonprofit sector. We've talked a lot about some of the challenges of dealing with the for-profit sector, but again, as we've seen, this sector is very, very diverse. And we have Dana Hovig, who is the Director of Integrated Delivery at the Bill and Melinda Gates Foundation. So the motivation for this, as we started to frame this whole plenary session, was that Alma-Ata and the whole primary healthcare movement was really conceived around a model of publicly financed and publicly provided healthcare. And I think there was really very little thought given at the time to what the private sector might be. I mean, it may have been small or it may have been just neglected. But I think we've been stimulated by both these presentations to realize both the pluralism of healthcare systems and the great mix within a system, but also the heterogeneity of systems across countries. We're looking at a really diverse world. And so what I wanted to do was to structure a conversation that would bring together this variety of perspectives, innovators and entrepreneurs, policymakers, for-profits, non-profits, researchers, and really to think about how we might go forward to challenge our polemic and to have a pragmatic conversation about how best we can engage the private sector in moving towards health systems that will serve the needs of all. And so we're going to talk a little bit about now, a little bit about the future, and then a little bit about how we get there. And I'm hoping that if I'm able to manage the time well, and if my guests here will help by giving their answers quite short and brief and concise, that we'll be able to engage you in asking some questions as well. So you'll notice that there are microphones 1, 2, 3, and 4. And when I get about 2/3 the way through the conversation, I'll pause and I'll ask for some comments or questions from the floor. So the first thing I'd like to do is to generate a mini word cloud here amongst our panelists. I'd like you to say the one word or a very brief phrase about when you think about the private sector in UHC, what is the idea that comes to mind? So Githinji, can I ask you to start?
I think the first thing I would say is that those who have little in life deserve more in law.
Okay, thank you very much. Akaki.
Yes, asymmetry between public and private.
Asymmetry, excellent. Harry.
That's a lack of technology.
Okay, excellent. Dana.
Yeah, I would say 2 words, inevitable, which sounds like it could be begrudging or not. And the second word is opportunity. I think what we saw from Catherine is particularly in the OECD countries, which might be a predictor of the natural arc of how health systems move, that the private sector delivers most primary healthcare services. So it's a bit inevitable. The question is, will it be pro-poor? Will it be high quality? And with that, I think there's a lot of opportunity.
Abhay.
I'll just repeat, social logic has to prevail over profit logic.
That's a paragraph. 2 words.
Social accountability and social regulation.
Great. Catherine?
Well, I'd go for incentives. No, by no means the complete explanation of anyone's behavior, but we ignore them at our peril as we try and bring those two together.
Okay, thank you. So as you can see, we do have a wide variety of perspectives and a wide variety of ideas to come into this conversation. So Akaki, I wanted to start with you. You come from Georgia, where the private sector is the dominant provider of health services. And you've also got experience of leading your country through some pretty major health reforms. What are the main challenges for governments and policymakers in engaging with the private sector? And what sort of capacities do they need to do this well?
Thank you. Just 2 words about the background, because otherwise it will be difficult to explain. 2004, we have Rose Revolution, government who is strong-minded, with strong belief in laissez-faire market, and for all sectors, including healthcare, which made Georgia one of the top 10 reformers, easy to do business, and especially very easy to do business in healthcare. So what happened, the results after 14 years, we have still laissez-faire market. We gave public money to private insurance, and with obligation to restructure, invest in the private, in the infrastructure and equipment. As a result, we have restructured, positive result. Restructured market, infrastructure, which is modern, more MRIs and CT scanners per capita than Japan, more hospital beds than required, and each bed, it's a very old belief, we know, each bed installed gets bed filled. So because of supply-induced demand, we have 99%, we have over 60% private expenditure. We have 95% private provision and 99% pharmaceutical retail provision and supply. So I would say that Georgia is a paradise for researchers for basically counterfactual scenario, in fact. What if, how, and if you can achieve universal coverage with this kind of dominance of the private sector, and what most important is at what cost, if it is possible at all. And just to say, what we have now is basically the problem with what happened that after laissez-faire market believers could tell that based on the judging from the results that we have, 30% of the population have a catastrophic expenditure because of the pharmaceutical expenditures, which are like 40% of the total health expenditures. That's unheard. 60% of expenditures of households are related to the pharmaceutical as well. And guess why? Over prescription. We, as you said, Abby, it's like universal healthcare principle, more care for those that in more need. We have more care for those who have no need. Because that's so cheap. It costs so little, and you can reap a lot of profit. And I can tell you that based on the results that we have, that this invisible famous hand of Adam Smith is broken. And in medical terms, not only broken, but have a complex fracture. Because it's broken in many places and many times. So that's the problem that we have, and which cannot be, I think, dealt just with solutions. And you said it's all right. I mean, we need to have some complex solutions, because some of my colleagues in government believe that, okay, Now we had lured these private investors in with the cheap free lunch in the private sector. They had restructured the sector. We have now modern equipment. So now we can struck them with regulation. But it's not that easy because it's a resistance. And just to finish, and we can talk about later on what is the prescription in this case or whether it will work. But believe me, there's a major resistance. It's major resistance hidden and also very open. And I think that the only way is to really align incentives. And in that case, I agree with Catherine that you cannot prohibit, you cannot nationalize, because we tried that 100 years ago, the country that I was born in, Soviet Union, this approach, and didn't work, and not end well in general, that kind of approach. Prohibit, then what? We have 195% private provision. So who will provide the services then? So it's constrained, they resist the constraint, and governmental capacity, when I talk about asymmetry, because capacities are asymmetrical. Government to regulate, public, private, because they know more. You nurture someone very bright in the public sector, they lure it to the private sector immediately with higher salaries, and so on and so on. Asymmetry of information, asymmetry of interests, but if we align, and if we make private sector profitable by observing, it's okay, in other words, moral and ethics doesn't work unless they're profitable. So that's how we need to align the incentives.
Thank you. So I'm a bit overwhelmed by some of these metaphors. I've got a complex fracture of the hand, but of the invisible hand. But I was kind of thinking,
it appears.
It appears. We need an MRI scanner to be sure. But I also think that we've got an issue of the genie's out of the bottle. So once your genie is out of the bottle, and in some ways it's not unlike India actually, with the genie out of the bottle, what can you do after the fact to try to create some structure with which you can shape the actions of the private sector? So maybe, Abhay, I'm just going to ask you this question about government regulation. You've talked about social regulation, and I think you're drawing very much on the resources of social organizations. But if you were to think about government, what are the capacities then that government needs to do to try to create this structure around the private sector?
Well, of course, today the public health system in countries like India itself is quite weak. And the capacity to deliver even public services is, under some amount of pressure, let us say. But we need an aggressive expansion of the public system and also of the regulatory capacities by bringing in expertise. I think younger professionals would be willing to work with the public system. And also we should bring in social expertise, because it's not just a technical issue. And for example, inspections of factories in some of the Scandinavian countries are carried out by trade union representatives, and that makes sense. So why cannot we also have social inspectors or bodies which include, patients' rights groups, which will work with the public system and which will bring in, experiences, information, and help the public system to act in a better way. So the public system needs to be energized through social inputs and through social action also.
So some new capacities and some new insights from the public.
And there are examples of well-functioning public services systems also in India. So, and we can learn from some of those.
Yes. So even within India, there's a tremendous amount of heterogeneity, because it's important to remember. So we talked a little bit about government's problem with the private sector. Harry, you are an entrepreneur. I would like you just to tell the audience a little bit about what you do, and then just comment on what are your problems with government.
Well, to begin with, I think I have to put a disclaimer, and the disclaimer is that I'm new to healthcare. I've been in healthcare only for 3 years. Prior to that, for about 30 years, I was in technology services. So the good news is I know very little. And the bad news is I know very little. And so here comes a completely outside-in perspective to what is going on, and to set the context of what Abhay and others were talking about. India's healthcare spend is about, 4% of the GDP. Of that, 1% is from the public or the public sector spend, 3% is the private sector spend, right? So obviously, it is 3 times more prevalent. We don't have enough infrastructure. And to add to it, the government has chosen to move away from being a provider and has become a purchaser or a payer. I mean, now, I don't know if some of you are aware, we are talking about covering 500 million lives as part of the latest insurance program. What is the coverage we are talking about? about $8,000 annually for a family of 5. So the government has decided that for a country of 1.2 billion people with the kind of complexities that we have, trying to put together an infrastructure is not going to work very well. The ambitious plan of growth is to hit about 2.5% of GDP by 2030. So it's a long way away from what the need is. Yet, at another level, India's, if you look at the specialists and medical services and capability, 70% resides in urban cities, the 6 urban cities primarily, and probably about 30% is for the rest of the country. Now, what that means is that there is a dramatic level of asymmetry that exists between the need and the availability. And here is where people like us come. And so let's look at it. There are only 2 players in this whole drama, right? On one side, you have the patient who is looking for access, who is looking for affordability, and who is looking for high-quality service, safe and effective service, clinical outcomes. On the other side is obviously the entire ecosystem of government, the private players, the clinicians, the works. And what are they looking for? Obviously, they're looking for capacity optimization. They're looking for ability to have some level of, I would say, some kind of regulation that allows them to do things and not in a restrained way or a constrained way, but beyond. And where does technology come in? And that's where I come in. So we are a company called Call Health, which saw the need and the opportunity being very, very high. And we know that in the current pattern of medical professionals being churned out, India will never be able to really meet its needs for the next 15 to 20 years. And to take Kathy's question forward as to how do you look into the future is where we came in. So we said, let's leverage technology to bring about a change in the healthcare ecosystem. And every other ecosystem has managed to do it. You talk about transportation, travel, e-commerce, everywhere. Technology has brought in dramatic changes into collective consumerism. Whereas when it comes to healthcare, we continue to operate in a very, very traditional way. And I'm talking about healthcare services. There is obviously phenomenal advances in technology when it comes to diagnostics and treatment and surgery. But when it comes to access to services and ability to disintermediate layers, technology has not played a role in this place. So what does Call Health do? Or what do I think technology companies and private companies can do is to actually wireframe the entire system that we can enable access to healthcare for people in remote locations or in far-flung locations where it's not available, and bring forth faster and easier access at their convenience. So I think that's something that has been missing, and we believe that's one of the things that Call Health does. Another thing that we think we will need to do, and that's where we are headed out, is Abhay put it very subtly, I think, when he said there is kickbacks in corruption. And I can only say that since I am an outsider into this industry, I was appalled at the level of, if I may say so, indulgences that were happening at all levels. And one of the things that we have done is to disintermediate layers by saying that we could actually work with the diagnostics labs and the pharmacies and bring down the cost by almost 50 to 70% compared to what it was in terms of a rack rate. Now, why is an MRI today charged at $100 in India, when today after we have come in, we have been able to bring down the MRI cost to about $50. And that's purely because there has been a layer of gratification that has been happening in different pockets. I'm not saying this is all prevalent, but please do recognize that that has been happening. So we have been able to bring in a digital layer and reduce the whole dependency of a payback that has to happen in different sense. So that's where we have managed to do. Technology can bring forth a change in the way access and in the way costs can be brought down as we go along.
Thanks, Harry. So that's, I think that's such an interesting perspective about how technology can help to structure markets in a way that might make them work more efficiently. I think we might come back to this issue of who's helping to mediate the relationship between the providers and the patients later on. So, Githinji, you run a large nonprofit. So, If you were to just say, just briefly, what do you do at AMREF, and where do you see the role of organizations like yours as you look ahead to the future, to somewhere like Kenya, where AMREF is headquartered? What do you see the health system of the future looking like, and where do you want an organization like AMREF to be contributing to that?
Thank you very much. I think first, I don't work with the researchers like Catherine, so I'd like to do a very quick poll. How many of us here have never used private healthcare? Okay, who has used private healthcare? Oh, thank you. So at least we're, it looks like we're all on the same side, that actually private healthcare is needed. We are using it ourselves. And I think the challenge I see before I go into the role that AMREF Africa does is that private sector, as we know, and all the data that has been presented by Catherine here, is created out of market incentives. It's a demand and supply. I think for us to say that there's a problem with the private sector is like saying you put milk in front of a cat and then you blame the cat for drinking it. You have to ask yourself first, how do you regulate and how do you provide conditions that protect the people against market incentives? I think that is really the big issue. And that is where we come in as the third sector or the civil society. We look at government as predominantly looking at the public good, as was presented, the social good, but in many cases, this social good may not be sustainable in some form or other. And on this other side, you have the private sector that is driving a profit logic, as was presented. And the private sector is existing, especially for-profit private sector, is existing because people want to create and to benefit from market incentives. In fact, I find many of our governments encourage young people to look for jobs. They encourage nurses to find jobs for themselves. We encourage young pharmaceutical technologists to find jobs for themselves. And when they go and open small pharmacies and small nursing homes, we now blame them for it. I think the issue is that we cannot blame them for it because the market sector will exist. The question is, when you come to health, why are we discussing private sector? Why are we not discussing the ills of private sector in agriculture? Why are we not discussing the ills of private sector in education? It is because health is first and foremost the most fundamental human right and the most fundamental public good that we can offer our people. And therefore, as we look forward to the future, we must look at this fundamental human right and say, how are we going to provide it for the people? And then we must protect them we must give them financial protection, we must give them quality, access, and we must then decide how to provide that. So if the existing market is able to have norms and standards, not necessarily regulation, norms and standards, and then we enforce those norms and standards, then we don't have to worry about is it private or is it public. So for us, what we come to do as an NGO is to work, one, on the government side, looking at social good, and on this other side, looking at private sector and becoming the broker in the middle. So if you have to look at the carrot and stick, in a place where there is no regulation, the carrot is too fat and the stick is too thin. So we are basically the ones who come into the market to chop the carrot a little and fatten the stick so that there's a balance between the profit and the social logic, and at the end of the day, we provide accessible public good, which is health, which is a human right, and make sure that the public, at the end of the day, is the one that benefits, not private sector or the government.
Thank you, Githinji. So, Dana, you work for the Gates Foundation. Now you have a previous life in working with Mary Stopes International and with Population Services International. So loads and loads of experience of actually working with the private sector. I'd like you to answer two questions. One is, what's wrong with the way we're thinking about the private sector? And the second is, what is your vision of the future? So when we get past 2030, we get into the 2030s, what do you think we should be aspiring to in terms of a health system?
So I want to build on a couple of comments that I've heard from our colleagues. First of all, at the Gates Foundation, we ironically believe that the best way to work with the private sector is actually to strengthen government and government stewardship roles, to work on that ecosystem level, because we don't want to pick winners and losers in the private sector and then create that sumo wrestler that Abhay showed. We think that, that government role and public provision, public payment is critical to the future of health systems. And so if we work there, we create the right ecosystem, the right incentives, then we think the private sector, the world of Hari, will really flourish in that. So I think having worked from the private provider perspective in MSI and PSI, having tried to reach up into government to influence how government works with us, we think that maybe we have a privileged position at the Gates Foundation to help that stewardship role. We also believe, we did some visioning recently at the Gates Foundation about what do health systems of the future look like 20 years from now. And so let me try to paint a picture of a vision. And that vision can benefit rich people, or that vision can benefit poor people. And because of the path dependency of health systems, the decisions we make today are going to decide that. Is it going to be pro-poor, or is it going to be mostly for the rich? That future is likely to follow other sectors. It's going to be much more consumer choice. It's going to be a distributed model of healthcare. It's going to be a mix of virtual and physical. One person said, will primary healthcare facilities be the Blockbuster Video of the future? If you know the Blockbuster Video story, they hung onto their business model, they hung onto their bricks and mortar, feeling like they were going to be a one-stop shop for entertainment, and then fairly soon they went out of business. And in a distributed model, do bricks and mortars have preeminence, or are they just many, many little distributed points where people have choices to go to? And in that vision, the private sector is going to play a huge role. It's going to be entrepreneurial. It's going to be innovative for reasons that Hari talked about. It's going to test out new business models that I think the public sector needs to understand, embrace, and incentivize to be pro-poor. Catherine said one thing, and this is the last thing I'll say, is that there's often the argument that, well, purchasing and contracting is hard. And we've given a grant recently to AMREF to help governments in Africa to help them purchase smarter and better from both public and private sector providers. We actually think service provision is hard. Delivering quality is really, really hard. So contracting or purchasing is certainly hard, but it can't be harder than actually delivering the services yourself. And the wonder of purchasing and contracting is you can actually switch out the low-quality providers for higher-quality providers. It really allows you to manage markets in a way which put governments in charge, but harnesses all the assets a country has, including public and private sectors.
Will you allow me to be in discipline and add something?
Only if it's very brief.
Thank you. Very, very brief. The other role we play is strengthening the community to make choices so that we can address the power of asymmetry that was talked about the other time.
That's an excellent point. So this is becoming kind of interesting then. We're thinking about both the need to strengthen government institutions, to be able to engage with the private sector in ways that will bring it to public benefit, and at the same time being able to harness some of the creativity and the innovation that comes from the private sector. But I think we're also kind of recognizing that it's hard to purchase well. It's hard for government to develop those capacities. And actually the same governments that are having a hard time purchasing well are also the ones that are having a hard time providing well. So we've got a rather complex system here. What I'd like to do now is just take some comments and questions from the floor. So I'd ask you to line up at the mics if you could, and I'll probably allow 4 or 5 questions all at once. You can either direct them at the whole panel, or you could direct them at an individual respondent, and we'll see if we can spend some time getting some energy and ideas from the floor. Could you start, number 1, please start by saying who you are and where you work.
My name is Mustafa Hunter. I'm an independent expert in private sector and governance and working with different UN agencies in fields of governance, anti-corruption. Thank you first for bringing this topic. I've been around it for a decade now, and it was more or less ignoring the existence of private sector. So now we're beyond the weather, and now we're thinking of the how and the future. And what you're saying here is definitely that the absence of a policy vacuum creates a massive undermining of the equity in the health sector, but also the wrong policy, which just also takes us there. So I think we should think how a good policy should be. The second thing, I think we should focus on a stewardship, strengthening capacity on how we see the system. Third, on a regulatory capacity. Fourth, on a decision-making process on where and how and where to bring the private sector in or bring the different components of the public sector. And one point that really also need to be integrated is integrity and equity, because the public health community, to my opinion, are the only ones who stand for that. The private sector acting for inequitable, they will say it's not our business, we're making the profit, and it's really not their business for the time being. So how would you see now, like, standing for equity as an issue and integrity and public health values through the private sector? So I think this should be the common agenda. The second thing, there is a whole bunch of evolution on the side of the private sector, from social responsibility to strategic social responsibility to ESG index, sustainability indices, the UN Global Compact, which didn't have health on it, impact investing. How to leverage in that? I think the H is missing there. We had the ESGs, we had environmental impact, social impact. There's so much pressure was done on the private sector that isn't this the time to bring the H in the triple bottom line formula, not only environment and social values? And thank you.
Okay, thanks very much. Number 2.
Thank you so much. Good morning. My name is Eckhard Kleiner. I work for the USAID-funded Human Resources for Health 2030 project. Thank you for an interesting and entertaining panel. I would like to ask about the role of data and to address social inclusion, equity, and quality, we need good data. We are in many countries having it from the public sector, but not so much from the private sector. So with the increasing availability of technology, especially mobile technology, and also the introduction of national health insurance, what can the private sector do? What does the public sector need to do to give us better data about what the private sector does, which we know nothing about in many countries? How many people are working in the private sector? What services does it deliver? Thank you so much.
Thank you very much. Number 1.
I'll be very brief. I know you've got a lot of people standing at the microphones.
Tell us
I wanted to really...
who you are and where you're from.
Oh, I'm sorry. Admiral Son is going to find you in trouble with medicine. I wanted to challenge Dana, because he said, why should service provision be harder than indirect control via contracting and regulation? And I think the answer, and has been addressed by much research in the past, that those are very different capacities of government required to manage to manage services and to regulate and control in an indirect way. And we have plenty of examples of governments capable of managing things in a hierarchical fashion, of getting services and products delivered. But I think the indirect mechanisms needed for contracting and regulation are far more difficult, and witness all of our current developed world governments capable of delivering health services but not capable of managing contracts, like in this country, whether it's the trains or whether it's security or cleaning or prison services. We have loads of examples of the failure of contracting. So I think we can only address that by thinking hard about what capacities governments need for different sorts of tasks and how to encourage that. Thank you.
Thanks, Anne. Number 3.
Good morning. I'm Sulakshna from the People's Health Movement India. So I mean, we've been talking about evidence, but I think there is overwhelming evidence on the failures of public-private partnerships, outsourcing of hospitals. I mean, right now, there's been a series, this experience with the PPPs, including in England. So I don't think there is any dearth of experience on how the private sector has failed to provide services, social public services, and it's a pity actually that that all that is not really being discussed. I've been to many sessions, but that experience is somehow not being discussed, of the failures of the private sector in the contracts, their performance, with the government. Second, I would continue from what my previous speakers have talked about in terms of the publicly provided services. So as a taxpayer, I would rather that, my money, my public money, the public funds go into a publicly provided health system rather than to the private sector, to a for-profit sector. So, that's where I'm coming from. And I think wherever we've had publicly provided services, whether it was, Thailand yesterday, also there was a great presentation on Thailand. And I think that has not been emphasized at all, and it's very important. And third point I would make on conflict of interest, and I think taking it from the first plenary, all of us should have worn badges of conflict of interest, because I see a number of private agencies here. Obviously you will, if you're a profit-making agency, you would, these issues of conflict of interest will come into when you're, propagating for certain policies. And I would specifically, actually, the gentleman from Gates Foundation has spoken about how their emphasis on publicly provided services. Now, recently, 2 weeks back, your colleague in India has written an article on the 4 or 5 lessons from Thailand for India, and he has not, and they have not mentioned that, in Thailand, more than 70% of the hospital services are being provided by the public sector. So that they don't see as a lesson for India. So I would request all of you just take into account these 3 issues. Thank you.
Okay, thank you very much. I'm going to, if you don't mind, I'll just take these 2 people who've been queued for a while at number 2, and then we'll stop and we'll take a round of responses. And then we'll have to stop the questions, I think.
Thank you, and good morning. My name is Tawfiq Jordar. I'm from Bangladesh, working with FHI-360. So I want to propose some extension to Catherine Goodman's introductory remarks, where she said that, well, discussing about or comparing public and private sector, we really need to specify which type of private sector we are talking about. So Githinji put it very eloquently that private sector is inevitable. We are all using it. And it is providing job. It's actually creating some benefit to the society as well. So the inevitability of private sector is kind of accepted and well established. So having this as a background, we need to actually find where it's not working exactly. And in doing so, it's very important not only to pinpoint what type of private sector we are talking about, we also need to be very specific about the parameter of comparison. For example, we can't make a blanket statement that private sector is good or bad in terms of quality of care or whatever parameter we are talking about. We need to break it down into smaller pieces and find out in which particular aspect of that parameter private sector is doing well or vice versa. For example, in my study, which was published a few months ago in Health Policy and Planning, we showed that responsiveness, we compared the responsiveness of public and private sector physicians in Bangladesh, and we found that in 3 aspects, in general, private sector did well in terms of this scale that we used. But when we broke it down into smaller segments or components of responsiveness, we found that friendliness, respecting, information, in these aspects, private sector did better, while in terms of gaining people's trust and financial sensitivity, public sector did better. So we know exactly where to really focus our intervention and improve those aspects. So with this, I end. Thank you.
Thanks very much. Okay, and our last question or comment, please.
Good morning. My name is Russell Rensburg. I'm from the Rural Health Advocacy Project in South Africa. I probably want to take a step back and say it's about private sector involvement in universal health coverage, right? And I think the premise of that is that we want to expand coverage to those who don't have it. And I am a little bit surprised that we're continuing the supply-side approaches to understanding healthcare provision. It's about what we can do as opposed to what the health market is saying. There's still a significant unmet need in areas in mostly rural areas and even within urban areas for access to healthcare services or basic healthcare services. And I think when we start the conversation about who is involved in that service provision, it must be premised on how we can expand access and quality as opposed to who can do a better C-section or who can service a flu patient a little bit better. And I think that the discussion hasn't included about what the gap is and how we collectively as public sector and private sector can fill that gap. For instance, in rural communities, there's no diseconomies of scale, but we also struggle with attracting and retaining healthcare professionals in the public sector. But there's no market incentive for the private sector to go there. So we'll find that private sector involvement is generally when there's a concentration of people and a concentration of access, and that's why we end up going into this cherry picking. I mean, you could have a health facility just focus on sexual reproductive health next to a primary healthcare clinic, and they will do better because they will just focus on sexual and reproductive health. So I think we need to look at the market, not just from the supply side, but what is the demand side and where are the market failures. Thank you.
Thanks very much. So there were a lot of interesting points there. Some of them were directed at individuals, and some of them were rather more general reflections and observations. Dana, there was a specific challenge to you, so I'd like to give you the chance to comment on the capacities for contracting and how those differ from provision. But then I might ask Githinji just to comment as well on how one thinks about strengthening the capacities for contracting.
Yeah, and I'd like to address the last speaker too about the supply versus demand side too. But the safest place to be in any conversation like this is to always agree with Ann Mills. And I'm sorry if I was inarticulate before. I didn't mean to imply that service provision is easy. I mean, is harder than contracting. Both are hard. Both are very, very hard. I've delivered services. I've also cut a bunch of contracts with private sector providers. Both are really hard. You can make mistakes in all of them. What I tried to say was that in a lot of conversations we've had at the Gates Foundation with partners, we often feel that it's too hard, governments can't do that. Contracting and outsourcing is a red herring. It's a way to hide from the hard choices that one has to make. And there are choices, and so both are hard, I think. On this supply versus demand side, I do think, coming back to the issue of health systems of the future, that we know today that people are agents of their own health care. They spend hundreds of hours every year on their own health. They spend a couple hours every year in a facility, and yet we focus a lot on what's in the facility. We don't focus on the rest of what they do day to day to improve, produce, or to destroy health for themselves. Health is personal. Health is private as well as public, and I think that isn't discussed here. I think with technology, with opportunities for the future, that people can be improved consumers, better agents of their own healthcare, make better choices tomorrow than they do today. And with better choices, I think, comes greater social and citizen accountability for health systems. And so I think there's an opportunity here to really think about that demand side and the future and how they square to better health, hopefully for poor people, hopefully in an equitable, value-based way.
Thanks, Janet. So Githinji, just a quick moment, and I suppose it's quite important to stress that when we talk about increasing government's capacity to be a good purchaser, that we are not necessarily talking about purchasing only from the private sector. We're actually talking about how the public sector gets, how government gets better service and better services and value from their own facilities as well. So could you just briefly comment on that effort that you're making in your new project to help strengthen government's capacities to be a purchaser?
Good. I also agree with Ann Mills, okay?
Yeah.
Just to be safe. Now, yeah, you can clap for her, actually. Not for me. You see, the issue is, today I was reading an article about the National Health Insurance Fund, or in fact, in Kenya we call it the National Hospital Insurance Fund, which is a misnomer. And the article says that the NHIF, which now covers maybe, I would say 20% or 25% of the population in Kenya, has undergone private capture. And most of their reimbursements are being paid to the private sector. Why is that so? That is so because the incentive environment has been favorable to the private sector, and therefore the private sector has provided more of the care because they know they get more reimbursement, therefore they improve their quality so that they get more, and in the process they also dictate prices. I don't know how many of you know that in a situation like that, the National Health Insurance Fund, when they negotiate for reimbursement for a cesarean section, for example, they pay private sector more than they pay public sector because the private sector justifies that these are our costs. These are the challenges that we are going to face. But these challenges can only be surmounted not by blaming the private sector, but by strengthening the capacity of the National Health Insurance Fund as a government agency and strengthening the capacity of the Ministry of Health and the government as a whole to decide what to provide for their people through the universal health coverage agenda, how to purchase it, and from who and at what prices. And that is really where the challenge is. So the challenge is not on the player, the challenge is on the referee. So for us, through the grant by the Gates Foundation, which is coming on improving the capacity for governments in Africa to do better strategic purchasing, our role is to work with the Ministry of Health and Ministry of Finance through their different instruments to start to understand the market dynamics, understand the fees cost pays of how much money is available, the benefits they want to offer, and set together to work, say, who best provides for these benefits? And there are benefits that will be provided by the public sector predominantly, and there are benefits that will be better and more efficiently purchased from private sector. But when you come to that point, how do you purchase, from who, what do you pay? Those are the conversations we are having with the governments in Africa through what we call SPAC, which is the Strategic Purchasing Africa Resource Center, supported through the Gates Foundation.
Okay, thanks very much, Githinji. Did you, I'm going to actually, we've got about 5 minutes left, so I'm going to begin to wind us up by giving everyone a chance to say one thing, and that will be either a response to some of the comments you've heard, or to think a little bit kind of the how do we get there? What does the future look like, and how do we get there? So what is the priority issue from your perspective? So whether it's from a policy perspective or from a research perspective, what would you see as the key priority moving forward in thinking about the relationship that we have with the private sector? So actually, why don't you start, Akaki, since you're right here.
Okay. First of all, let me comment on the couple issues that have been mentioned. One, yes, I mean, it's a good example, what I've seen in many countries, of the question that was posed regarding management versus regulation skills, and they're completely different. I had seen many ministers who had been an excellent managers of facilities, but very poor ministers when they became the ministers because they lacked the skill of policy making and regulation. And regulation is far more complex in the countries like low and middle income countries than it is in, because it's all matured high income countries, you have all the institutions in place. Here you need to juggle into sometimes and really have the ways, very creative ways to do it. So, and believe me, one thing is that, okay, everybody in the auditorium, I think, is for pro-poor policies. And that's what we all researchers and policymakers are also declaring. But believe me, this only exists in the ideal world. There are no pro-poor policies without buy-in from rich. Believe me, either you convince rich that pro-poor policies are good for them as well, because poor doesn't revolt, or maybe solidarity, and maybe that they would enjoy a better social cohesion and better world in general without poverty, or you provide actual benefits. Otherwise, believe me, in real political economy situations, you cannot only implement, enforce, and adopt legislation that's only pro-poor, unless there is buy-in somewhere else. And the key for that, no silver bullet, I agree, but stewardship function, which includes a strategic purchasing, which includes a good regulation, and first of all, aligning the incentives. We need to repeat the same way. We need to align incentives for private sector, for them to be profitable while being ethical and observing morale.
Thanks, Akaki. I think also you made a very powerful case for universalism. There are no pro-poor policies, so policy has to benefit everyone. I think that's a very powerful thought for us to take away as well. Harry, you could comment briefly on the data issue, but also, what do you need to do going forward to think about how we structure a system that can engage the private sector in a constructive and effective way?
So I think one of the biggest advantages that technology will bring is transparency. And when I say transparency, it is the ability to trace evidence-based medicine, whether it was followed or not. It is the ability to move from a very curative, episodic engagement with the provider or the clinician to a continuum of care. And to answer the other question around data, we just covered 100,000 tribal students in remote places. We did a health screening, and we now are providing a 24/7 one-year care for them in terms of treatment. I believe that has been possible because we've been able to bring together all the pertinent information and make it available in interesting dashboards and perspectives. So one of the biggest things that I'm going to kind of advocate for is probably a singular regulated system around the EHRs and the EMRs, and to have probably a tighter focus towards interoperability of processes between the different players in the healthcare ecosystem. But there is nothing more powerful than having transparency of data and information which can make decisions and traceability and auditability a much easier task as we go forward. So I would just vouch for that and leave it at that.
Okay, thanks very much. Catherine?
Well, I guess I wanted to pick up on the data question we had as well and link that with the incentives we were discussing earlier. I think we should consider that operating as a private provider, it is a privilege. It is something you are granted a license to do by the government, and there should be things you have to do in return for that privilege. And you talk about technology, how that can help us with data, but we also need to make sure we've got our incentives right, that you don't get your license if you don't provide us with the basic data that is needed to study the health system as a whole. And I also think we need to think about, we've talked about incentives for good quality, but we can't do that until we can feel that we're confident in how we're measuring quality. And I think maybe that's one of our real challenges going forward, to try and work out how we can purchase from the high quality and drop the low quality provider. How do we actually do that, and how do we do that with robust measures?
Thank you very much. Abhay, let's start with you. We'll work in.
Yeah. So I'll sort of comment on and draw upon some of the questions from the audience, and I'd like to say 5 things, which can be done or need to be done. The first is we have to strengthen both public provisioning and public regulatory capacity, and we need innovative ways of doing this. Without that, we cannot move towards UHC. Number 2, regulation cannot follow after purchasing, which is being done in countries like ours. So we first, start paying the providers, private providers, and then later on think about regulating. That's not going to work. So regulation has to precede and accompany the purchasing process, and it has to be, developed in a very integrated way. That is the second. The third is that we need to think about partially socializing certain private providers. I'm using this term. The NHS, the private practitioners in NHS in this country are a good example of that in the original NHS. But as I understand, it's what we are talking about is, in a sense, taming the profiteering of the private sector and bringing them under the social logic. So they don't give up making profits. They continue to make certain kinds of profits, but that is within a certain boundary. I think that is what is the crux. And that partial socialization, you may not agree with the term, but the concept is that, so when we say that, then we have to take a differential approach. And we have to look at, are these big corporate hospitals with international investments, are they going to come in that, or the smaller providers, the individual providers, are they going to be more amenable? So getting a decent income is something which is very much compatible for the healthcare providers, very much compatible with UHC, but maximizing profits to fulfill global investors may or may not be. And that is where the differential approach, I think, should be brought in, which I don't find being discussed. And finally, that they have to have a strong element of social accountability in a rights-based mode. Health and healthcare are human rights. They must be fulfilled. We have to move toward UHC, but with a strong focus on people's rights and right to healthcare. Thanks.
Thanks, Abhay. Dana?
Well, I'll be very brief because the other speaker said largely what I was going to say. I would say 2 things, quality and equity. And the reason I say those is because we talked about the private sector, but these are challenges for the public and the private sector, is quality and equity. And the UHC agenda, which we endorse and fully support, risks being about quantity, more coverage, more people, more money. And Margaret Crook and others have been so eloquent at saying, coverage without quality equals 0 health production. So quality and equity, I think, are critical to private sector and public sector provision.
Thank you very much. Githinji?
I think what I would like to say in closing is, today, my mother, who is asthmatic and lives in a small rural town in Kenya, if she felt some chest congestion and she still has a national health insurance card, the most likely thing she'll do is that she'll call my neighbor, who is a clinical officer, who provides private care, and ask him, what should I do because my chest is congested? That's what she's most likely going to do today if she has chest congestion. So, and I know that even after we leave this conference, we, in the next few weeks or months or year, we are still going to consult, including our speaker, Abhay Shukla, is still going to consult a private doctor on some issue. So I don't think the issue is about whether private is good or bad. The issue is that if we achieve a truly proper, publicly stewarded universal health coverage, this whole topic of whether private or public will die. In fact, even Catherine's research is going to shift from whether public or private to shift to what works for government stewardship, how, and what are the governments doing it best and what can the other governments copy? And that is strategic purchasing for pro-poor UHC. Thank you.
Thank you very much. Gosh, so we are actually out of time. I hardly dare to summarize, but a couple of things just jumped up to me as I was listening to these closing comments. One is the sense is that, that things will change to respond to a policy vacuum. So we do need to structure the policies that we want to have so that we end up with the health system that we want. Otherwise, things will just happen, as Catherine pointed out. I think this issue of sequencing is important. I think it relates a little bit to the genie in a bottle issue. If we let that genie out of the bottle entirely, it's very hard to put it back in. So to think about what needs to happen in what order in order to avoid some of the worst risks. Another issue that came through to me was the idea of, we sometimes talk about pay to play, but I think we can reverse that and say that you've got to play to be paid. And so if you're going to be part of the system, that is a publicly financed system, there are certain obligations that come with that, whether that's to report data, whether it's to adhere to certain levels of pricing and to certain levels of quality. But I think we can insist that people play the rules of the game in order to benefit and be paid by it. And I think if we have those rules right, then we will be able to construct a system that is able to meet the healthcare needs of everyone. And that's what we are here to discuss. So please join me in thanking my spectacular panelists. And with special thanks to Abhay and to Catherine for setting us off on such an interesting discussion. Enjoy your coffee.
Thank you.
Thank you, everyone. Please give a hand for Cara for handling it extremely well. Cara?